Good morning, everyone. I'm Mark Arthur. I'm the chair of the department, as you all know. We're doing rounds today on critical care research during the COVID pandemic, and Dr. Deb Cook and Dr. Bram Rochberg are going to do rounds today. Bram's actually driving, and he's using not using an actual computer, he's using an Apple product, and so he has some limitation on muting people. So if people aren't muted when they come in, I will call people out. I'll keep an eye on who's making all the background noise. So I apologize in advance if I call you out specifically, but it's the only way sometimes to stop the feedback. Rounds are being recorded today and will be available on the department's YouTube channel later on today. We've had amazing uptake of that. So I'll just pass it over right now to Dr. Rochberg and Cook.
Thanks, Mark. I'm going to get started. It's a delight to do this round with Mark. I'd just like to give a shout out to all our colleagues in the emergency room, internists, anesthesiologists, the ICU docs in the community. We've got two sections to go through. I'm going to kick us off. Bram is going to kindly advance the slides.
Trying, sorry.
From Gail. And next. In the spirit of conflict of interest, both of us are very involved in various projects related to the pandemic in different roles. I'm going to carry on to just jump into the phenomena of the World Health Organization's mandate, a moral obligation, one might say, that everybody get involved in trying to understand and mitigate the ravages of the pandemic. You'll notice there's no researchers in any of these bubbles here, but Bram and I are speaking from the point of view of clinicians and clinician researchers. I know on behalf of so many of us wanting to try to stave off the morbidity and reduce the mortality in the days to come. So next, I want to just alert you to Canadian National Collaborative that's been prepared to try to coordinate some of the activity going on in Canada. And this is very different than when SARS and H1N1 was even going on, to try to facilitate the work we do together and minimize unnecessary redundancies, because with H1N1 there are enormous number of redundancies in the public health crisis mitigation efforts. So McMaster, if you'll go ahead, thanks Bram, has been key in producing many of the collaboratives, and you're going to hear about some of them to come. We also hope to play a more important role coordinating with colleagues outside of our country, around the world. And this is one of our many strategies to try to enhance communication, at least in the clinically relevant randomized trials that are going on and will go on in weeks to come. Thanks to Mark for recognizing McMaster's central role in this effort. So first I want to tell you about the period prevalence study that is called the SARIC Initiative, or SARI. It's just to let you know this is one of the first World Health Organization initiatives since the pandemic to try to encourage more data sharing than has been common in some previous efforts. And the next slide will point out the home of this effort is at Sunnybrook Hospital. And the idea is here that we'll quickly be able to have a very brief case report form to identify and better characterize patients who have acute lung injury and without acute lung injury with COVID-19. So we're hoping everybody will get engaged in that. Critical care research is a place where many of us practice primarily. And in contrast to the large amount of clinical critical care research that goes on, the pandemic-specific research mandate in previous years has been only a modest proportion of the work that we do. And the situation is very, very different nowadays, as you'll hear about. So the next slide outlines some of the problems we had with H1N1. And because there was a similar frenzy to try to do clinical research, we realized we had to try to modify things to have more efficient protocol development with better stakeholder input, and call on our research ethics colleagues to have a better coordinated, more rapid RAB response, and that has already happened here in Canada, as you know, especially in Hamilton. And we need to think about the consent models because this is a very tense situation and often families are not present. So we want to have more global alignment. After the H1N1, if you go to the next slide, Bram, we also did a study to try to identify what the potential problems were with doing H1N1 research in critical care arena. And Karen Burns led this study, and it was obviously the voice of research coordinators that was very relevant here. And for a lot of the drug studies that have gone on and will go on, there's a big a workload for research pharmacists, which we wanted to acknowledge. But as you can see, 28% of the research coordinators at that time thought there were too many ongoing studies to allow the initiation of H1N1 research, and that's not what we want to see in the coming months. So the next slide shows some of the ideas that a few of us on the couple weekends ago got together, Michelle Coe, Eric Dwan, Walid Al-Hazani, and myself, trying to think through some of the principles involved in clinical research in the ICU community during a pandemic. And while there is this obligation we have to try to better understand and mitigate the ravages of the pandemic, we know that each individual needs to benefit, but we also have to maximize the benefit to society. While we want to advantage patients with COVID-19, we don't want to disadvantage patients without COVID-19. Of course, there will still be many of those. And this acknowledges that many of the studies that are going on in the ICU community are relevant to patients with COVID-19 coming up. So what we now have is a much broader portfolio of COVID-specific research, and you'll hear about the details from Bram. It's not just drug-related interventions, but convalescent plasma and physical approaches like proning that you hear more about. And this distribution is very unique today compared with a decade ago with H1N1. We still wanted to delve a little deeper into what's suitable to do, though, in the basic research that goes on as a background. So we've talked a lot about social distancing, but as we know, it's not social distancing, it's physical distancing. Clinical research is extremely social endeavor, and with the mandate to work remotely, it makes any study in the ICU almost impossible if you look at it on the surface. So what we wanted to do is try to understand what could be done while honoring physical distancing. And so you'll see some of the procedural modifications we thought about for observational studies when research is a public good and we want to just document and characterize what's happening with COVID-19. Maybe consent might be waived in some situations, deferred RCTs and deferred consent rather for many RCTs using phone consent, telephone communication, with our research pharmacists, and also some of the remote safety approaches. And data collection obviously is being done remotely more and more, with obviously a focus on getting the primary outcome and trying to do alternative to in-person approaches using video assessments. So we thought that we would propose that the conduct of research in the ICU that is pandemic focused, it is a basic hallmark, but we thought that it would be possible to do research that is not pandemic focused as long as it is safe for staff, research staff, bedside staff, as long as it is feasible and as long as it's locally approved. So we developed this framework to consider study by study which studies might be paused, which might be pursued, and acknowledging that this all needs to be periodically revisited as the pandemic ensues. We're also mindful of many important WHO mandates to continue to try to evaluate and reevaluate what we think are the best proven interventions that we implement in practice to ensure that they are safe, effective, efficient, accessible, and represent quality metrics. So these were the fundamental underpinnings to our approach. We at St. Joe's took a portfolio of some of the randomized trials that are going on. And it's important to notice that there's some individuals have been preparing their whole life, or at least the last decade, for this moment, doing pandemic RCTs. One of these individuals is John Marshall, and he and colleagues have had, shall we say, a sleeper protocol for patients with community-acquired pneumonia called REMAP-CAP that is ready and is now sort of being tweaked in order that it may serve patients with COVID-19. But there are an array of newly developed RCTs that are relevant for patients, sometimes on the ward, but also in the ICU. You're going to hear about these from Bram. There are 3 big studies going on related to septic shock, one of which is FISH, I'll talk about in a moment. But early in the game, the vitamin C investigators and the folks interested in anticoagulation in the LOVEIT and the HALO trial also explicitly repurposed their trial to try to help patients with COVID and see whether or not vitamin C or full IV therapeutic heparin had any effect on mortality. Wanted to focus on these last 3 RCTs, which we think are still highly relevant in the days ahead. And I'll go ahead and tell you briefly about them. So FISH is led by Bram Washberg, and obviously we're studying septic shock patients who will receive always resuscitation, either high or low chloride fluid resuscitation. And benefiting from a pilot trial, FISH has demonstrated its feasibility in a multi-center way, and it is ongoing now during the pandemic, and we have approval to continue. So Bram, if you'd go on to BALANCE. BALANCE is another randomized clinical trial that is testing for patients with bacteremia whether there's any difference between 7 and 14 days of antimicrobial therapy. And it's a non-inferior design led by Nick Daneman, one of our ID colleagues, and Rob Fowler in Sunnybrook. And this too is still highly relevant for today. The next slide is about REVISE, evaluating whether or not proton pump inhibitors are useful for minimization of clinically important bleeding, which may well be the case, and fueled by a pilot that Walid Al-Hazani led. This now too is a multi-center study, and the focus is on not just bleeding, but the possible risk of nosocomial infections, which may be higher in patients getting acid suppression. So these are the 3 that we thought would be reasonable to pursue. And Bram, the next slide goes through our general approach. And we thought, let's consider the status of the pandemic. Obviously, if things get crazy, patient care trumps everything, and we can't do any research whatsoever. With jurisdictional guidance from our local community scientific and hospital leaders, as well as Mark Inman and Fred Spencer, we thought this through. Speaking with many of the research coordinators in the community, we went ahead to look at each of these studies in turn and thought carefully about supply. So as we know, there's many drug studies going on, and there's a drug supply shortage. Some of the pandemic proposals across the country involved every other day doing nasopharyngeal swabs on people. So obviously, if that happens, we're going to run out of NPS for diagnostic test purposes, which doesn't make sense. And clearly the infection control concerns and minimizing the wastage of PPEs is of paramount importance. So the next slide shows the way in which we went through 5 of these sample studies. There's a weaning study from mechanical ventilation with once versus twice weaning assessments led by Karen Burns, and we thought that's a reasonable protocol perhaps to put on pause. The RTs obviously are going to be in the rooms of ICU patients periodically, but maybe that would involve more PPE use than would be ideal. As you know, rehabilitation is crucial for our critically ill patients at all times, including pandemic times. Speaking with the PI, Dr. Michelle Coe, we realized already there's going to be use of PPEs for rehabilitating patients who are critically ill, but due to the decontamination, sterilization concerns about the equipment of the cycle ergometer, that might be reasonable to put on hold. And you can see the decision for FISH and REVISE and the BALANCE study led to our notion to continue. There's no extra utilization of PPEs for these latter three. For the balance study, there's no research pharmacist that is required, because as long as clinicians have equipoise, it's 7 versus 14 days of antimicrobial therapy. And the research pharmacists are very helpful in preparing study drug or placebo for REVISE, and the 2 different fluid preps for the fish study. So just wanted to show you our approach with some concrete examples. So in summary, we did benefit very much from speaking with our colleagues at Hamilton Health Sciences, and collaboratively came together through talking with Mark and our scientific advisors, ethics advisors, and said, okay, we're going to identify all patients who have COVID-19. We want to get great input from the research personnel who are helping every step on the way, and do some protocol modifications, like minimizing some of the biomarker testing to the extent that that would concern people taking serum and processing it and transporting it related to fish. So that's where things land at the moment. And since the obligation for staff to stay home, since we revisited this whole process in close contact with Mark Crowther, we have continued these 3 trials, including Bradford General Hospital, which has a very active research program. And you can see just in these 10 short working days, we have enrolled patients with and without COVID-19 in these 3 RCTs as the population element to them. Next. I'm worried about co-enrollment. For many years in the Canadian Critical Care Trials Group, through conversations that Maureen Mead has led nationally, and we've had a lot internally, we've been liberally co-enrolling patients in trials in the ICU. Of course, this is carefully crafted according to ethical guidelines, workload guidelines, and importantly, scientific guidelines to ensure that it is reasonable. And each of the different trials that are going on in the COVID-19 period will be considering in terms of what's possible for co-enrollment. So just as a backgrounder, that's quite different than a factorial design. We're talking about either sequential or simultaneous co-enrollment of 1 patient into 1 study. In that other study, if you go to the next slide, could be an RCT and an observational study, or it could be 2 randomized trials. So what we wanted to do is just let folks know that while we know that clinical research for the sickest patients in the hospital and the ICU is really, really important, our research enterprise must not impede our clinical response efforts, and our directors and colleagues and ID and IPAC, everyone everywhere is working hard to ensure we have a safe clinical response. But also under the auspices of distributive justice, we want to make sure that while focusing on some patients, we don't potentially disadvantage others. And in fact, while research is known to advantage many individuals, we also want to advantage all of our patients to the extent that we can. So patients with and without COVID may benefit from clinical research, but we thought it would be important to just share that even studies that would be so-called pre-pandemic may be reasonable to continue if safe, feasible, locally approved, if the study integrity can be ensured, and in consultation with key stakeholders. We've had a really great cross-city approach, talking with Emily and Maureen and Allison and Bram and all the folks I mentioned that thought about this first at St. Joe's. So our decisions are always going to be proportionate, transparent, and revisited. So we're looking forward to determining something useful at the pandemic with all the RCTs that are going on. And Bram, hand this over to you.
Thank you, Deborah, and good morning, everyone. Both my pleasure to be helping with rounds this morning. You know, the response with this pandemic over the last few weeks has been unbelievable, I think, across Faculty of Health Sciences and Department of Medicine, and seeing frontline clinicians stepping up, researchers, administrators, and the amount of work that's gone into planning it's been unbelievable, and I think a testament to our group. I also wanted to say that it's an honor to follow Deborah in terms of presenting this morning, someone who's been an incredible role model for myself in terms of combining academic clinical work and research, and being so thoughtful with all aspects of research, especially in challenging times like pandemic response, falling back on principles and ethics and prioritizing the advancement of science, even when we're all stretched with rationed reasoning. It's incredible. So it's great. A lot of that earlier work I used to push forward with FISH, both in my own mind and amongst the community. And truly, I think, lucky to have such leaders here in Hamilton. My part of the talk today is the fun part, is talking about the unique and interesting trials that are ongoing, both in the ICU, but also in the wards across Hamilton. I by no means can hit on all of the work that's been done. I think the research response to this pandemic has been unbelievable, and there's lots of important studies that are ongoing, but I'm going to try and focus most on randomized controlled trials, and specifically the ones with the Hamilton connection being led by folks here, and sort of recognizing the hard work that's gone into those. In advance. Great. So you've already heard a little bit about this first one, the REMAP-CAP trial. I can't remember exactly what the acronym stands for. Randomized, embedded, adaptive trial in community-acquired pneumonia, something along these lines. It's an international trial, randomized controlled trial, with an international steering committee. But we do have great Canadian representation on that international steering committee. With these three gentlemen pictured here. Some of you may remember Francois Lamontagne in the first picture. He did his ICU training and research training here in Hamilton under Deborah and Maureen's guidance and mentorship, and now practices in Sherbrooke, Quebec. John Marshall in the middle from St. Mike's, and Srin Murthy is the last picture, a pediatric intensivist based at BC Children's Hospital. And I mentioned it's an international randomized controlled trial, currently enrolling at 50 sites. You can see a predominance in the Australia, New Zealand area in association with the ANZIGS trials group, enrolling across Europe, a Saudi Arabian site, and increasing sites in Canada as well. The REMAP-CAP trial is up and going at St. Joe's right now under Deborah's leadership as local PI, and I know that we're working hard at getting it going at the Jaravinsky. We're very close, hoping to have it ready in the next week or so, as well at the General under Dr. Alison Fox-Robichaud's leadership. I know that they're working on trying to get it up and going. And it's very cool. This is, I think, one of the most unique trials that we'll discuss today, in so much that they have integrated a pandemic response pathway as part of this randomized controlled trial. And it recognizes the fact that pandemic respiratory illnesses happen at regular intervals over our history. This is looking back as far as 1500, the year 1500. And you can see that relatively regular time frames we've experienced these pandemic respiratory illnesses. And although REMAP was originally oriented to enroll patients with community-acquired pneumonia of any cause, as Deborah alluded to, there's a respiratory pandemic component that as soon as we experience the next pandemic illness, i.e. in this setting COVID, is that they can activate this and specifically orient treatments to that pandemic illness. I'll try my best to frame the PICO from each of the trials that we're going to talk about. So in terms of REMAP-CAP, they're specifically enrolling critically ill adults. This is one of the few trials that's specifically oriented towards those that are critically ill. They're looking at capturing patients within 48 hours of hospital admission with LRTI symptoms, as well as radiologic evidence of infiltrate. Patients have to be relatively sick, receiving either non-invasive ventilation, invasive mechanical ventilation, or on pressors inotropes. And they're excluding patients with hospital-acquired pneumonia or those that are at risk of imminent death. I will talk about the interventions and comparator in the next slide, because it's a little bit more complex than your straightforward randomized controlled trial. The primary outcome here is 90-day mortality, but certainly capturing morbidity following ICU stay as well, which is increasingly being recognized as a truly patient-important outcome from randomized controlled trials in the critical care setting. So this is the cool part about REMAP, is that there's multiple domains. And some of these domains are specific to this pandemic as well. So patients that are randomized can be randomized to any number one of these domains or multiple domains. And so there's an antibiotic domain, and you can see that patients that are randomized within the antibiotic domain may receive one of 5 different antibiotic regimes. There's a macrolide duration domain. So patients within this domain may receive either 3 to 5 days of macrolide or 14 days. A corticosteroid domain, in which patients may receive placebo, a fixed 7-day course of corticosteroids, or shock-dependent steroids, so only receiving steroids if they're in shock. There's an antiviral domain, in which patients may receive placebo or a combination lopinavir-ritonavir, and an immune modulatory regime domain, where patients may receive placebo, interferon beta-1, or interleukin-1 receptor antagonist. And as Deborah mentioned, with the predominance of anticoagulation or coagulation pathway dysfunction that we're seeing in some of these COVID patients, and this thought that they may be prothrombotic, Ryan Zarakansky and Ewan Gallagher, intensivists from Winnipeg and Toronto, are looking at getting funding for adding in therapeutic anticoagulation domain, which may form a 6th domain within REMAP. So how does this look? Each site can decide where their equipoise persists, and some sites may choose to enroll patients in a couple of domains, or may choose to enroll patients in all 5 or 6 domains. So if a patient proves eligible, let's say your site is comfortable with enrolling in multiple of these domains, is that when you log into the randomization online server and you plug in your patient details, is that patients would get randomized within each of these domains. In essence, answering multiple questions within the same study. So maybe one specific antibiotic regime, a certain macrolide duration, a steroid use plan, and either receiving antivirals or not receiving antivirals. And then patients are followed for their outcomes. Currently, 115 patients have been enrolled in REMAP worldwide. The uniqueness of the adaptive design allows us to answer multiple questions within the same research infrastructure, thereby improving research efficiency, reducing costs. It really is unique, because if we were to look at 5 different interventions and compare them amongst each other within separate individual randomized control trials, you'd be looking at performing 10 separate randomized control trials. It's a ton of work for anybody who's run an RCT before. If looking at this figure here on the side, is that if you're able to study these different interventions within the same adaptive design, you can get away with, again, much less research infrastructure and much less costs. One other interesting adaptation that this allows is that based on interim analysis, you can actually favor your randomization to specific interventions that are showing more promise. You can see here, for example, drug number 2 is that at interim analysis number 1, if it's showing more promise as being efficacious with less harm, you may favor more randomizations, more eligible patients get randomized to drug number 2 as you go on. Whereas other interventions, for example, drug number 4, which are showing less promise, you may decrease or even eliminate those domains as you move on. So very novel approach to answering multiple questions within the same design. Moving on from REMAP, the ACT trial is just getting going and led, although not specifically an ICU trial, led by 2 of our very own smartest and brightest, Rich Whitlock and Emily Belli-Cote. And this is the anti-coronavirus therapies to prevent progression of COVID-19 trial. This has been this is one of these new COVID trials, but in speaking to Rich and Emily, I know that they were able to design the protocol in a very rapid fashion, from what I understand, even over a weekend, which, having seen the protocol and the rigor that's involved in it, is unbelievable that they were able to put this together so quickly, acquire funding, support from the pharmaceutical companies to move forward with things. Also, a unique aspect within ACT is that there's actually two arms within the same trial. There's an outpatient trial, which they're looking to enroll approximately 1,000 patients, and an inpatient trial looking to enroll about 530 patients. They're looking at adults with confirmed COVID positivity, and patients in the outpatient trial are being randomized 1-to-1 to receive azithromycin and chloroquine plus usual care, the Donald Trump regime versus usual care alone. Patients randomized within the inpatient trial are actually looking at multiple arms in 1-to-1-to-1 allocation, the azithromycin, chloroquine plus interferon beta. There's another arm that's looking at just azithromycin and chloroquine, one just looking at interferon beta, and one placebo or usual care. Sorry, it's not placebo controlled and blinded, but rather compared to usual care. And they have a complex process that they've put in place that every positive test that comes through at the local center, for here all our testing is done at St. Joe's, so every positive test gets flagged, and they have a team of research assistants that are calling out to the patients, enrolling them over the phone, so using some of those tools that Deborah alluded to earlier, confirming eligibility, providing a consent encounter over the phone, and then arranging for shipping of study drugs to the patient's house for the outpatients, or ensuring that drug is available at the inpatient setting. And again, they've had interactions with pharmaceutical companies to ensure that there's adequate drug supply and that the shipments can occur. In the outpatient trial, their primary outcome is a composite of hospital admission and mortality. In the inpatient trial, a composite of needing invasive mechanical ventilation and mortality. They're also looking at important secondary efficacy outcomes, admission to hospital, renal replacement therapy use, extracorporeal support, as well as translational outcomes, looking to see whether these medications affect viral titers or ACE2 levels or other measures of inflammatory cascade. Another homegrown randomized control trial, again, not truly an intensive care trial, but one that is going to be enrolling in hospitals across Canada at least, is the CONQUER-1 trial, a randomized open label trial of convalescent plasma given to hospitalized adults with acute COVID-19 respiratory illness and run by Dr. Donald Arnold within the Department of Medicine. Donnie's somewhat of an honorary member of our ICU research community, having trained with Deborah and Maureen and part of our academy academic group. And I should mention one of the other fun aspects, perhaps fun is the wrong word. There's not a lot in this pandemic that's necessarily fun, but it's nice to see a lot of our colleagues getting recognized for their work. And I mentioned Rich and Emily already. They were highlighted in the Hamilton Spectator last week. And Donnie, for those that may have seen, was in the Globe and Mail earlier this week, as well as in the Hamilton Spectator. So it's nice to see the lay press recognizing the hard work of our scientists at McMaster with a lot of the work that's being done in the context of this pandemic illness. The idea behind convalescent plasma is also unique and interesting, is the fact that we have this population, especially an increasing population of folks that have had COVID-19 and have recovered from their COVID-19 illness. And we suspect that there's at least transient immunity with recovery. I don't know if it's going to be lifelong, probably not, but at least months or years, is that these people have developed neutralizing antibodies that are circulating in their plasma. Probably they prevent reinfection within themselves. And is it possible that giving this plasma to patients that are infected and sick with COVID might help recover their illness faster? They've looked at doing this even as far back as the 1918 influenza outbreak. They've looked at it in SARS, MERS. You may be familiar or remember that they looked at it even in Ebola during the outbreaks in the last few years in East Africa. So Donnie and his group are looking at whether giving convalescent plasma in the setting of COVID-19 to hospitalized patients may prevent their progression of disease to requiring intubation and ICU care. So specifically looking at adults admitted to hospital with COVID-19, receiving supplemental oxygen, and there would have to be availability of an ABO-compatible convalescent plasma unit. They're excluding patients with impending intubation. So this being their primary outcome, they are not wanting patients that are critical to the point of needing to go to ICU imminently, but rather trying to capture patients on some amount of oxygen who are on the ward. Interestingly, and thankfully, there's no limitations on co-enrollment with drug trials. There's a bit of an issue with so much work that's being done, good work that's being done. Deborah alluded to some of the principles around co-enrollment, and it's certainly best as a local principal investigator to be able to help and contribute to science amongst a number of interventions. So it's nice here that co-enrollment is not a problem. And they plan to enroll 1,200 patients. I believe they have funding for all 1,200 in a 2-to-1 randomization schema where 800 of those patients will receive convalescent plasma, 400 will receive usual care. And they're actually confirming adequate levels of antibodies. They didn't want to just give plasma and be uncertain that there was the necessary antibodies within. So they're checking titers of anti-SARS-CoV-2 antibodies prior to transfusing these units. The comparator here is standard of care. Primary outcome looking at intubation or in-hospital mortality up to day 28. I swear my cough is not related to the current pandemic. They are collecting their first convalescent plasma units, hopefully within the next week or two, and plan to hopefully enroll the first patient in Concord before the end of the month. Also, again, a huge testament to being able to mobilize resources in a very, very facilitated and expedited manner. Moving on to discuss the CATCO Solidarity randomized controlled trial. This is also an international effort, which I'll discuss a little bit more about, and at least in Canada is being led by the same Srin Murthy that you'd heard about before. This is sort of Srin's area of expertise, longstanding. We hear him speak at Trials Group often about pandemic illnesses, and only now I feel like is he getting the attention that he deserves with all of his hard work. You'll often hear him being quoted in lay media and this sort of thing. But the idea behind this is that, at least at the WHO level, there had been previous pre-pandemic organization around this trial called Solidarity, with the goal of producing a global mega trial aimed at enrolling tens of thousands of patients using a common case report form, a common analytic data set, in order to answer these questions in a generalizable way, really doing it on a big scale. So they're looking at hospitalized adults with COVID-19, and similar to REMAP, the goal here was an adaptive intervention schema. You can see that there's 5 different domains within Solidarity, looking at antivirals, hydroxychloroquine, immune suppressives, and supportive care, with the primary outcome being hospital mortality. So CATCO is the Canadian arm of Solidarity. So Solidarity is going across the world. Srin has applied for funding specifically for CATCO, which he's going to use the Solidarity case report forms and organizational structure and feed this data into the worldwide data set. But he has put together a Canadian DSMB, a Canadian steering committee, and running the trial out of Sunnybrook Hospital in Toronto. COVID-prone is another trial in earlier stages of development being led by Dr. Walid Al-Hazani, looking at proning in non-invasively mechanically ventilated patients requiring high FiO2 in the setting of COVID illness. So adults with COVID that are hypoxemic while on higher FiO2s, greater than 40%, with an infiltrate on chest x-ray. We've still had a little bit of discussion amongst the protocol whether we would only include patients on high-flow nasocannula and non-invasive ventilation, or whether patients on a venti mask would potentially be enrollable as well. So still working through a couple of these important concepts. The intervention being awake proning as compared to usual care, with a primary outcome of intubation within 30 days. The idea behind proning, and we use proning in our severe, moderate to severe ARDS patients anyhow, but routinely we normally only use proning in those that are mechanically ventilated, those that are intubated. This is a CT scan of somebody's lungs with ARDS. The back of the patient, the spine is on the bottom, their dorsal side at the top. And you can see that the crap in their lungs, the mucus, the secretions, all collects at the back. This based on gravity. However, blood flow also works by gravity. So blood flow is going to be best also to the patient's back. And this is a classic example of what we call a VQ mismatch. Ventilation is best at the top of the lungs, but perfusion is best at the bottom of the lungs. And the idea behind proning is that we switch patients over, turn them over so that they're lying on their stomach. Again, we routinely do this in mechanically ventilated patients. And at least transiently, we're now maximizing perfusion to the area of the lungs that are best ventilated. Over a little bit of time, that crap from the back is going to collect to the front, and we're going to run into problems with VQ mismatch again, so we flip them back. It sounds all well and good, but for those that have participated in proning, there's risks with proning in terms of pulling lines out, extubating patients, this sort of thing. And patients that are this hypoxic, if they were to, God forbid, extubate while proned, it's probably a terminal event. So we do prone, but we're very careful with how we prone. But the question that Walid and his steering committee are asking is there benefit to doing this proning in non-intubated patients as well? This is at the Jarovinsky in our ICU, and an example of not real patients, but one of our intensivists and one of our charge nurses, and they're actually proned over onto their stomach in the ICU beds. And this would be the idea of doing this in the ICU or on the ward. I should mention as a quick side point is that this is one of our ICU rooms up at the Jarovinsky, which routinely we only usually have one patient within. But as part of our planning work in the last few weeks is that we discovered is that each of our ICU rooms have medical air for 2 patients, suction for 2 patients, oxygen for 2 patients, and adequate plugs and monitoring devices. So we've now moved, one of our adaptations over the last few weeks is we've moved to now putting 2 patients in each room of our ICU. And we have, you can see here, 2 ventilators, 2 monitors set up, 2 stretchers in the room. And this has provided us opportunity to double our ICU capacity at the Jarovinsky from 25 patients to 50 patients without even leaving the footprint of our ICU. So we have options to leave, to go to PACU, same-day surgery, this sort of thing, but we're able to get to 50 patients without leaving our footprint. Obviously, patients would have to either both be COVID positive or both be COVID negative, but I just thought I would use that as an example to highlight the innovation and adaptation that is also happening in clinical care in the setting of this pandemic. I told you that we've done our best to highlight some of the trials, especially those with a local flavor. There's lots of other work and important work that is being done outside of the ones that I've mentioned. There's an industry study being led by Roche that Zain Shagla has helped with, looking at tocilizumab, which is an anti-IL-6 anti-inflammatory agent in COVID-19. We actually use this at the Jarovinsky more commonly in our CAR T patients, our CAR T therapy patients in diffuse large B-cell lymphoma that have developed cytokine release syndrome after receiving CAR T. We'll often give tocilizumab, but folks have investigated its use and will be investigating its use in the setting of COVID. Claudia DeSantos, a translational researcher at St. Mike's and ICU clinician, is looking at profiling the host response to COVID, looking at gene array and proteomics, and some of us, including Alison Fox-Robichaud, have been helping here in the Hamilton context. Francois Lelouch in Montreal is looking at oxygen auto titration device. The idea being is that if we're looking after many patients, we might not be able to adequately titrate or respond to oxygen titration needs as quickly as in other settings. So a device that will automatically titrate FiO2 based on a patient's oxygen saturations. Margaret Herridge at Toronto General has done so much important work around the recovery trajectory after critical illness. And we recognize that given the volume of critically ill patients with COVID that we anticipate to see, there's going to be an enormous population, hopefully, that survives their critical illness. And now we're going to have to focus on what recovery looks like and the recovery trajectory. And Margaret has applied for funding to specifically look at how this looks. And Deborah's already nicely summarized the observational trial Sprint Sari that I know Michelle Coe here in Hamilton and others are going to be helping with collect data for. So on that note, I think that leaves approximately 15 minutes for questions that we'd be happy to take, but very, very much appreciate your attention and listening to both of us this morning.
Thanks, Brandon and Deborah. So what I'll do is Mark Crowther, there's a number of questions in the chat, so I'll just ask them and then maybe we can move on to opening up people's mics. So the first question is, Will Harper asked, do we know what the mortality of patients who get onto a ventilator is as opposed to 4 weeks ago?
It's a great question, and it is context specific. It depends on, obviously, the number of ventilators that any setting actually has, the propensity to intubate versus use non-invasive ventilation. It is very, very context specific. So Sonny Coley, as many of you know, Sonny, he was a critical care trainee here in Hamilton, was just letting me know that half of their patients had just died of the ventilated patients they've cared for. And it's going to vary profoundly. So there's no single answer to that estimate. And I think some of the studies that Bram has reviewed when examining mortality as obviously one of the important endpoints, arguably the most important, it will depend upon the catchment, the inclusion criteria, what the intervention actually is. Some interventions may be more likely to influence mortality than others. And depending on the inception cohort, the intervention, different target mortalities will be considered in the trial design, but there's no single answer to what the mortality is of mechanically ventilated critically ill patients. If we knew how to mitigate the risk of death, very clearly we'd be doing that and trying to make the rate lower than anticipated, but our efforts in Hamilton are largely designed to lower it, whatever it is.
Thank you. Following along with that, there was a question about, are there any studies that are looking at different ventilation strategies?
Yeah, so we talked a little bit about COVID-prone, which is looking at proning non-invasively ventilated patients. I think certainly if you go on to clinicaltrials.gov, there's, the last time I looked, upwards of 200 randomized controlled trials in the setting of COVID-19, specifically looking at everything from ventilation strategies, immune modulatory regimes, chemotherapy agents, vaccines. So certainly there are. I'm not aware, Deborah might be, I'm not aware of any specifically being led by Canadians or through Canadians, although the Mechanical Ventilation Center at St. Mike's being led by Laurent Bourchard, I would be shocked if they weren't investigating this to some degree and looking at avenues. I know Tom Perano, who's also at the same center, has done a lot of excellent webinars around different strategies to ventilate these people. But the bottom line, I think I take away from a lot of this is, until we have good RCT data, is that to use our tried and true ventilatory practices for these patients, same as we would for other ARDS patients, is key.
Thank you. A specific question about use of fludrocortisone from Will Harper in patients with pulmonary lung disease. I'm very familiar with the corticosteroid data in ARDS, and if you look at predominant use, an agent that is used in the setting of ARDS is usually methylprednisone, with this theoretical benefit of better lung penetration. And in ARDS, at least, the data around using corticosteroids is quite good in randomized controlled trials. The problem is that when you specifically look at viral ARDS, there's a subset of observational data that is highly confounded, suggesting perhaps harm. So I think this is a lot of controversy about using corticosteroids and a lot of uncertainty. And about half the guidelines say use them in ARDS, and about half the guidelines say don't. So I think this is a prime area to study for randomized controlled trials. But as opposed to sepsis, perhaps, I don't see any specific advantage to adding on more mineralocorticoid agents here. And even methylprednisone, Will's an endocrinologist, he knows better than I do, but even methylprednisone and hydrocortisone still have a fairly good mineralocorticoid component.
Mm-hmm. Just to add to that, in H1N1, it was one of the frequently used interventions, sometimes in desperation moments, sometimes early, because as Bram's pointed out, it wasn't really clear what we ought to do for that. pandemic period. And in the end, what happens is people collect all the data from an observational perspective and then to do propensity matching and try to ascertain whether or not exposures like corticosteroid exposures have any influence on duration of ventilation or mortality. And at the moment, although there may be future RCTs examining corticosteroids, I'd imagine the Sprint-SARI registry that I spoke about will be one of the main databases used to try to establish that or estimate the effect of corticosteroids post hoc, just considering regression analyses and other methods. And that is one of the other key features that will distinguish these RCTs that Bram has summarized from RCTs from H1N1, because I'm sure not many people here would be able to think about one or two randomized trials that showed benefit from H1N1, because unfortunately many of them were not published. This decade, it's going to be very, very different, and we're going to be encouraging everyone to document co-interventions. So for example, in the Pronating trial, I'm sure Walid and Zainab are also going to document which other interventions have been given to patients, and likewise in Concord. So many of these key questions for old drugs like corticosteroids, I'm not sure we're going to be able to ascertain through a clear RCT, but it may be more adjustment analyses down the road that tell us post hoc.
Perfect, thank you. A sort of general question, so when there's lots of research going on and there's a generalized, not prohibition, but strong recommendation that research coordinators don't go into the hospital, how do you rationalize accurate data collection with limited on-site staff, particularly in centers that don't have really good electronic medical records?
Mm-hmm. It's a great question, Mark. We've consulted broadly France Clark, Lori Hand, Tina Millen, Nicole Zatarik, and others in Hamilton, several of whom I've not mentioned. The remote access of data has been set up quite expeditiously by many hospitals outside Hamilton. When there is obviously EMR, it's quite a bit more straightforward, but still the authority approval for that has to occur in a timely manner. But it's more than the data collection. It's also telephone contact with families, the lifting of the obligatory wet signature that's been characterized by so much research, especially Health Canada related in concert with conversations with Research Ethics Board. And then the oversight, the all-important oversight that Michelle and Eric and Walid and I have been talking about. A lot of that is possible to do by telephone, touching base with the hardworking bedside nurses, the incredible ICU bedside pharmacists and physiotherapists and RTs. So some of that can still be real time. It's just telephonic, not in person. So there are adaptations that are being promulgated to sort of follow this mandate to do pandemic research, because this question poses the dilemma exactly. Clinical research is not done just behind a computer, and their phone and social contact is necessary. So it's not social distancing, it's just physical distancing, and adaptations wherever possible are being made.
Perfect. Two more questions off the chat. One is about why, are there any studies looking at lateral decubitus positioning as opposed to just prone and whatever it's called, the opposite direction to prone?
Not that I'm aware of. And I think the reason we're specifically looking at proning is because of the data that we have suggesting benefit in mechanically ventilated, and wondering now whether that extends to non-mechanically ventilated, given a similar pathophysiologic rationale for perhaps benefits. We do sometimes use lateral decubitus in unilateral lung disease with the same rationale that you want to improve perfusion to the good lung. So, perhaps in patients that did have one impacted lung or one poor one lung that was preferentially affected by consolidation, you might put the good lung down. But what we've seen so far in COVID seems like more of a bilateral interstitial picture consistent with viral pneumonia. So it's not been specifically investigated.
Thank you. And the last question is an interesting one. I'm not sure if Donnie's on. I can't see his name in the list of people who are on, or anybody from Donnie's study are on. But the question is, are the patients who are contributing to the pooling of the plasma all hospitalized patients who are really sick, or is there a way of identifying, contacting, and enrolling patients who are less sick and who were able to go through the disease in the community to reduce the pool of patients who provide convalescent plasma? So I don't know if Donnie's on or someone's on from Donnie can answer that, and if not, I don't know, Bram or Deb, if you know anything.
Yeah, I'm here. If you can hear me, okay. So thanks for bringing this up. This trial is so multifaceted that it is a little overwhelming. So it's not just figuring out who the patients are going to be, but it's figuring out who the donors are going to be. And this is a really big collaborative effort between our blood services, so Canadian Blood Services and Hemo-Quebec, and they're doing a lion's share of the work to try to identify anyone who's recovered from COVID, regardless of the severity of their illness. So even mild disease who've had documented COVID, those would be perfect donors eventually once they're 14 days post symptoms. And if they have documented antibodies, they would be great to be donors for this trial.
Excellent. Thanks very much, Donnie. So that's all the questions that I think I saw in the chat. I'm just looking to see. Someone said lateral decubitus induces the previous match. We don't need to comment on that, I don't think. So if anybody out in the audience has questions, please just open up your mic. And then after you're done asking a question, please close it because you'll get feedback if you don't. So any questions from the audience?
It's Martha Fulford here. Can you hear me?
Yep.
Yeah.
Do either of you have any thoughts on the whole proning, or at least the positioning of a severely ill patient who might be pregnant? Because clearly we can't prone them. And we do have some very high-risk pregnant women. Say high risk in terms of their comorbidities. They're obese, they are hypertensive, they are diabetic, and if they do come in and requiring ventilation, any thoughts on positioning?
I mean, I certainly agree. I would not prone a pregnant woman. I'm not aware of anybody that's looked at this or done this, but it doesn't seem like a good idea. We're even in ARDS, we reserve proning for the more moderate to severe. So although certainly, God forbid, it's possible that a pregnant woman young could end up intubated with significant hypoxia and low PF ratios. But I would sort of just do our normal care ventilation practices and normal positioning. There's other contraindications, relative contraindications to proning as well. Sometimes body habitus just strictly limits our ability to prone. Sometimes patients have other reasons, facial deformities, this sort of stuff. So there are a subset of patients that we cannot prone for variable reasons, and I would put pregnant women into that category for sure. So, but I can't offer any other insights specifically into better positioning beyond just our normal positioning.
Any other questions from the audience? I will point out that someone named Laura has an open mic and causing feedback, so if you could close your mic, that would be good, unless you're going to ask a question. Any further questions from anyone? If not, I'll thank Dr. Cook and Dr. Rochberg for doing rounds today. That was really great. And I can't believe how quickly all this stuff has come together. It's quite a remarkable thing for many, many people who've done a lot of work. So congratulations. We will do rounds again next Thursday. Haven't quite decided on the topic yet, but we will figure out a topic. Probably, I hope to do some rounds that aren't COVID related, but I've had some discussion during the course of it with others who wanted to do another COVID related one. We'll see how it goes for next week. So thanks everyone for joining. Hopefully you have a productive day and that you don't have to deal with patients who are critically ill with this disorder. And thanks to Bram and Deb.